Now let's talk about psoriatic arthritis. What is psoriatic arthritis? It is arthritis seen in patients with psoriasis. Right. Sometimes what happens is patients with psoriasis can also have rheumatoid arthritis. So this is different from that. So what is psoriatic arthritis? Psoriatic arthritis is patient who has arthritis other than rheumatoid arthritis with psoriasis. Okay, so that is psoriatic arthritis. It is erosive arthritis, just like any inflammatory disease. So obviously when there is erosive arthritis, there will be destruction of the joint. So we have to know the criteria to diagnose psoriatic arthritis, because I just told you that patients with psoriasis can also have rheumatoid arthritis. So to make a diagnosis of psoriatic arthritis, you need rheumatoid factor negative. Okay, so psoriasis patient with rheumatoid factor negative. Other things that you need are X-ray changes, dactylitis, and nail changes. All of this together is known as Casper's criteria. This has been asked as an MCQ. Now, what is the sex predilection for psoriatic arthritis? It's equal in males and females, because this was asked as an MCQ. Now, let's discuss the joints that are usually involved in psoriatic arthritis, like how we discussed for rheumatoid arthritis and ankylosing spondylitis and osteoarthritis. Psoriatic arthritis can almost involve any joint. Right? So there is no specific joint, but usually it involves the DIP joint. The type of arthritis that you get in psoriatic arthritis is asymmetrical oligoarticular type. It's asymmetrical usually. It's oligoarticular asymmetrical type, and this again has been asked as an MCQ. Now, what will be the manifestations? The manifestations usually will be in the hand in the form of dactylitis, shortened digits, and destroyed finger bones. Okay, so let's look at this. There will be dactylitis. What is dactylitis? Inflammation of the fingers. So it will be like sausage digits, swollen digits, sausage digits. Okay, dactylitis will be there. What else? Shortening of digits. Because of the destruction and the erosion of the ends of the bone, the phalanges will be shortened. So there will be shortened digits. And when you pull on the fingers, the finger will lengthen. This is known as telescopy of fingers. Okay, bones are destroyed, soft tissue is there. So what will happen? You can pull the soft tissue, that is known as telescopy of fingers. And destruction of the articular surface in the joints will lead to arthritis mutilans. It's an erosive arthritis of the ends of the bones, total destruction of the joints leading to arthritis mutilans, totally destroyed fingers. Okay. On X-ray, what will you notice? There is a classical MCQ that is asked, known as gull wing or seagull sign, where there is destruction of the articular surface in the shape of a seagull gull sign. Okay, this is one MCQ. Another thing I want you to know is, because of the destruction of the articular cartilage, there is a specific radiological finding that have been asked on your exam, known as the pencil in cup deformity. What is this pencil in cup deformity? There is destruction of the phalanges in the shape of a pencil, in the shape of a tip, and this looks like a pencil which is inside a cup. Pencil in cup deformity has been asked as a deformity on X-ray in psoriatic arthritis. Okay. Also remember, this arthritis mutilans deformity is not exclusive for psoriatic arthritis. It can occur in any type of erosive arthritis, also rheumatoid arthritis. Okay, rheumatoid arthritis. So those are the things that you need to know about psoriatic arthritis. Treatment: treat psoriasis, and also for arthritis you can use methotrexate. Those are the things about psoriatic arthritis you should know. Next, talking about hemophilic arthropathy. So this is an arthropathy that occurs in hemophiliac patients. Can you tell me what is the cause? The cause here is frequent episodes of bleeding. Frequent episodes of bleeding, particularly in the joint, leads to inflammation of the synovium, which leads to destruction of the articular cartilage. That is the story here. Okay? It is obviously seen in hemophiliacs. They are usually X-linked recessive patients. The factor that is usually deficient is mostly 8 in patients who present to you with hemophilic arthropathy. Factor 9 deficiency patients can also present, but it's usually factor 8 deficiency patients. Now, what are the clinical features? I've just told you the pathology. It is because of the recurrent episodes of bleeding into the joint. Now, bleeding into the joint is one type of bleeding in hemophilic arthropathy. There are other places it can start bleeding in. It can bleed under the periosteum, subperiosteal bleeding. It can bleed into the muscle, muscular bleeding. It can bleed into the joint, causing inflammation of the synovium. Right? Inflammation of the synovium is what causes the destruction of the articular cartilage in patients with hemophilic arthropathy. But They've asked MCQs about bleeding under the periosteum and bleeding into the muscle also. So intramuscular bleeding usually occurs most commonly in iliopsoas. And when you feel for that bleeding which is collected in the iliopsoas, it feels like a swelling. This feels like a tumor, but since it's not a true tumor, they have been described as pseudo tumors. So pseudo tumors are basically bleeding into the muscle seen in patients of hemophilia. They ask you questions, which muscle is most commonly involved? You can say iliopsoas. All right. Now, talking about bleeding into the joint, how will it present? It will present with a massive swelling at the joint. Most commonly involved joint is the knee joint. You can see here a patient with bleeding into the knee joint. Whenever there is collection of any fluid into the joint, what will happen? The capsule will be stretched. And as the capsule is stretched, patient will be in pain, and to minimize the pain or reduce the pain, the patient will keep the joint in the position of ease. What is position of ease? A position of the joint where the volume of the joint is maximum so that the pressure on the capsule is reduced. Because there is fluid in the joint, it will push on the capsule and capsule will stretch, causing pain. So what will the patient do? The patient will position the joint in a way that the volume increases so that the pressure decreases. What is the position of ease for knee joint? It is flexion. What was for hip joint? We read in septic arthritis. It was flexion, abduction, external rotation. You know that. Anyways, so position of ease for knee joint is flexion. As the patient keeps it in flexion, the pain will come down. Obviously, when the patient is brought to you with a swelling, you will be tempted to remove the contents of the joint to reduce the pain. But don't do it, because we know it is blood in a patient of hemophilia, and if you try to aspirate it, there will be risk of infection. So aspiration is a relative contraindication. But if the pain is severe, then you can aspirate it to reduce the pain. Okay. And why is it a relative contraindication? Because we don't want infection. So these are the clinical findings. Now, what about the radiological findings? Clinical findings we have read. Radiological findings, because of this recurrent bleeding into the joint, told you there will be synovitis, which will lead to destruction, right? So what will you notice? There will be narrowing of the joint space, widening of the intercondylar notch, squaring of patella. And obviously, because of frequent bleeding and inflammation, juxta-articular osteopenia or osteoporosis, no sclerosis. No sclerosis. So wherever there is inflammation, there is no sclerosis. Please keep that in mind for now. Okay. So widening of the intercondylar space, squaring of patella, and narrowing of the joint space. What will be the treatment? The treatment is, for the swelling, don't aspirate unless it's severe in pain. Try to apply ice packs for the swelling, but treat the hemophilia, minimize the bleeding, right? So treatment would be to treat the hemophilia, do factor replacement, apply compression bandages, and ice pack application for the swelling. Try to resist aspiration of the swelling unless there is severe pain. Now moving on to crystal deposition arthropathy. Here what is happening is there is arthropathy, pathology of the joint, because of deposition of certain crystals which were not supposed to be there in the joint. Once these crystals are deposited in the joint, what is happening is there is a local inflammatory reaction because of these crystals. And when there is inflammation, there is destruction. Whenever there is inflammation, there is destruction. The body is trying to remove that crystal from the joint, but since it is unable to, it is starting to destroy other structures around it. So this is basically collateral damage of the joint because the body is trying to fight the crystals that is deposited into the joint. Now, why are the crystals deposited there? Normally, it's not supposed to. It is because of some abnormality in your body. Okay, so we have two conditions that we're going to talk about here: gout and pseudo-gout. You must have read about this a lot in biochemistry. What is gout? Gout is a purine metabolism abnormality because of which there is excessive production of uric acid in the body. The problem in gout is increased serum uric acid production. See, what is the normal serum uric acid? The normal serum uric acid is 3.5 to 6.5 milligrams per deciliter. It is the increase in the serum uric acid production that causes gout, which leads to the precipitation of the crystals into the joint. But please understand this. It is essentially the sudden increase or the sudden decrease of serum uric acid that leads to the precipitation. Okay, slow increase or gradual increase and gradual fall is not the problem. It is a sudden increase or the sudden decrease of serum uric acid that leads to its precipitation into the peripheral cold joints. And once they precipitate there, these crystals precipitate there, they cause inflammation. Okay, are you following? So there can be a patient whose serum uric acid is 9, may not have gout. There can be a patient whose serum uric acid is 7 and can have gout because there was a sudden increase of serum uric acid that precipitated the crystals in the peripheral joint, causing pain. Okay, so this sudden change is what you need to remember, and that's what will help us understand the treatment also. So this deposition leads to local inflammatory reaction leading to collateral damage. Okay, so purine, metabolism, serum uric acid, these crystals precipitating, causing pain. Now, classical history will be there for a gout patient. Remember, this will usually be a middle-aged man. A middle-aged man going on a business trip or a leisure trip. Now, why does the question mention business trip or a leisure trip? Because they are telling you that this person is going to have fun. Going to have fun as in eating a lot of red meat, drinking alcohol or beer. And when you do that, what happens? The serum uric acid suddenly increases. And when that increases, there will be precipitation of the crystals in the peripheral joint, causing acute gouty pain. So, usually males more than females, middle-aged, keywords will be alcohol. There are certain drugs that can also precipitate gout, like diuretics or aspirin. They tend to precipitate, uric acid in the peripheral joints. Acute gouty pain will be their complaints. Now, what happens is this serum uric acid suddenly increases or decreases. The crystal precipitates. The monosodium urate crystal precipitates the peripheral joints, particularly the first metatarsophalangeal joint, this joint. And when the crystal precipitates there, local inflammation reaction leads to swelling, rise in temperature, redness and pain, and eventually destruction of the joint. So this destruction of the joint will be visible on X-ray. Clinically, what will you have? You will have swelling, redness and pain. This swollen red first MTP is what is known as your tophi. On X-ray, what will you notice? Destruction. This destruction is there. Punched out lesions will be there, and because of destruction, some bone will appear like overhanging. This is known as overhanging or Martel's G sign. What is the investigation of choice? What is the investigation of choice when you're looking for a crystal that is precipitated at the joint? The investigation of choice is to aspirate the content of the joint to look for that crystal. So the investigation of choice is aspiration of the contents of the joint, the synovial fluid. Remove it out, and what will you find? You will find the monosodium urate crystals in the joint. What are the characteristics of this monosodium urate crystal? They are needle shaped, and on polarizing light microscopy, they are negatively birefringent. Very, very important. Okay? So monosodium urate needle shaped, negatively birefringent crystals will be found in the synovial fluid on aspiration of the first MTP. Treatment. Acute gouty pain, you should never give anything that will decrease the serum uric acid, because I've told you it is the change in the serum uric acid concentration that leads to the precipitation of the monosodium urate crystals in the joint. So your aim in acute gouty attack would be to minimize the pain. The drug of choice is indomethacin. Olden days we used to give colchicine, but the patients had GI disturbance, so nowadays we are giving indomethacin. Okay, never anything that will change the serum uric acid concentration, because what will happen? It will aggravate the symptoms. Only once the pain comes down, you will give any drug that will change the serum uric acid concentration. Either you can inhibit the production of serum uric acid or help in excretion of the excess uric acid in the serum. So how will you inhibit the production? By inhibiting the rate limiting enzyme in the purine metabolism. That is xanthine oxidase inhibitors. What are the drugs available? Allopurinol, febuxostat, rasburicase. Refer pharmacology if you want to know about the newer drugs. If you want to remove the uric acid that is there in the serum, you can use uricosuric drugs. A typical example is probenecid. You use this after the pain has come down, never in acute gouty attack. Is that clear, friends? Please remember that. Never in acute attack. Because in acute attack, if you use any of these drugs, you will be changing the serum uric acid concentration suddenly, precipitating more pain. Okay? That is the story of gout. A middle-aged man going on a business trip complaining of pain at the first MTP joint. Now, on the other hand, what is pseudogout? Pseudogout is also a crystal deposition arthropathy, but here the crystal is different. The demography is also different. This is elderly population, females more than males. And these are patients who are usually hypothyroid. Now, gout involved small joints of the periphery. Pseudogout involves large joints, most commonly the knee joint. So they will also complain of pain, but mild to moderate pain. Okay, older population, larger joints, mild to moderate pain. Investigation of choices, aspiration, what will you find? You will find calcium pyrophosphate dihydrate crystals. What is their shape? They are polygonal in shape and positively birefringent. So monosodium needle-shaped negatively birefringent is gout. Calcium pyrophosphate dihydrate positively birefringent. Polygonal is pseudo-gout. Right? One more important characteristic is that they will have deposition of calcium in the cartilage. That is known as chondrocalcinosis. That is known as chondrocalcinosis. So what is this term chondrocalcinosis? Deposition of calcium in the cartilage. This is seen in pseudo-gout, but can also be seen in other conditions. So the other conditions that can also give you chondrocalcinosis apart from pseudo-gout are ochronosis, hemochromatosis, and hyperparathyroidism. Okay, please remember that. Now, this is an image showing you the differences between gout and pseudo-gout in terms of the aspiration of the synovial fluid. You see monosodium urate crystal that is needle-shaped and negatively birefringent in gout, and you see calcium pyrophosphate dihydrate crystals that are polygonal shaped and positively birefringent on polarizing light microscopy in pseudo-gout. Now, the last condition in joint disorder that I want to discuss is neuropathic joint. Here what happens is the patient has a failure in the nerves. The patient has no sensation. In fact, the patient has no proprioception of the joint. When the patient has no sensation or the proprioception of the joint, what will happen? The position of the joint could be abnormal. It could be injured. It could be traumatized, but the patient has no sensation. And as it is getting injured and traumatized or being kept in an abnormal position for a very long time, what will happen? It will start to get destroyed. And it will be destroyed, but the patient will have no symptoms. Clinically, when you look at it, it might look like a deformed joint. It might look like a destroyed joint, but the patient would have no pain. And this is all because of peripheral neuropathies. So what is the most common cause of neuropathic joint? The most common cause is diabetes, because that is the most common cause of peripheral neuropathy. The most common cause is diabetes. And what is the most common joint involved in a diabetic neuropathy-induced neuropathic joint? It is the mid-tarsal joint or the tarso-metatarsal joint. The other conditions are leprosy and syphilis, where the interphalangeal joints or the knee is involved. So look at this X-ray. What do you look at this? What do you see on this X-ray? There is total destruction of the joints here. The mid-tarsal or the tarso-metatarsal joint. This is a neuropathic joint of diabetes. Now, what is the problem here? The problem is not there. If you look at the X-ray of a patient who comes to you with a deformed foot, the X-ray will look like the bone is destroyed, the joint is destroyed, the foot is destroyed. Clinically, when you palpate for this, you will realize that it's a bag of bones. There are bones that are destroyed, and when you feel it, there's total movement of the bony fragments here, and there's a bag of bone appearance. But the patient has no symptoms. Right? So signs actually outweigh the symptoms. The X-ray is more devastating than the patient himself. So this is what is the key thing that I wanted to remember. Now, you will imagine that since the joint is destroyed, the treatment would be to reconstruct the joint? No, never. Because even if you reconstruct the joint, since the patient has no proprioception and sensation, he will destroy the replaced joint as well. So arthroplasty is usually contraindicated in these patients. The treatment is to fuse the destroyed joint in whatever position it is, so that at least it is stable for the patient to walk on. Okay, so the fusion of the joint when you do it surgically is known as arthrodesis. In contrast to a disease process that fuses the joint, that is known as ankylosis. Is this clear? This is all about neuropathic joint and all about the joint disorders that I wanted to discuss. The aim of the discussion was to basically help you make the diagnosis by giving you the key differentiators radiologically, clinically, or based on the history to identify the diagnosis. And once you've identified the diagnosis, then the answer is in front of you because you know the theory. And where will you learn this theory? You learn this theory mostly in medicine and pathology. You know the treatment, you learn it in pharmacology. So this was the whole concept behind giving you this module of joint disorders to help you make the critical diagnosis that most of the students struggle on the exam. Now let's practice a few MCQs to see what we have learned from this topic. Okay, so the first question is, during performing a total hip replacement, the surgeon found destruction of the articular cartilage and multiple wedge-shaped subchondral depressions. What are these called? Okay, Are they osteolysis, osteomyelitis, osteonecrosis, or osteogenesis? So what did the surgeon encounter? He encountered subchondral depression. So subchondral, there were depressions. So these are your subchondral cysts, right? So what are these cysts? These are basically your osteonecrosis. That is the answer. Is that clear? Next. Patellar clunk syndrome is a known complication of which surgery? Yes, it is total knee replacement. It's of a total knee replacement. If you recall, what was it? It was basically a fibrotic nodule that forms at the superior pole of patella because of friction from the femoral component. And whenever the patient would extend the knee from a flexed position, it will lead to catching. That was your patellar clunk syndrome. Okay? Patient after total hip replacement develops breathlessness, which is the definitive management. So breathlessness post THR. What is the treatment they are asking? So you need to know what is the diagnosis first. This is a complication of total hip replacement where post-operatively, if the patient is not on DVT prophylaxis, will develop DVT, which will lead to pulmonary thromboembolism that needs to be treated immediately with thrombolysis. So quick recall, what are the complications of THR? Infections, dislocations, aseptic loosening, means the implants will loosen without infection, and pulmonary thromboembolism, which usually presents with dyspnea after surgery. That's why all these patients who undergo TKR or THR, they have to be kept on DVT prophylaxis. And if the surgeon is not very good or skilled, he might injure the sciatic nerve. So these are the complications of THR. Next question. In THR, metal on metal articulation should be avoided in. So what is this metal on metal articulation I told you? Right, the prosthesis, if it is made up of metal on the acetabular and the femoral side, you call it metal on metal. If there is a polyethylene on the femoral acetabular sides and metal on the femoral side, we call it metal on poly. If there is a ceramic, we call it a metal on ceramic. Or if the ceramic is used on both the sides, ceramic on ceramic. You don't need to know all that. You just need to remember that if you use metal on metal prosthesis, what will happen is as friction and attrition happens over the years, these metal ions come out, and these metal ions, they get into your systemic circulation and causes problems like nephropathies. And especially in pregnant females, they might cause teratogenicity or carcinogenic manifestations. So that's why metal on metal articulation is usually not preferred in young females who are likely to become pregnant. Okay, so what are the contraindications of metal on metal prosthesis? Patients who have hypersensitivity, pregnancy because their risk of teratogenicity and carcinogenicity, renal impairment. Okay, so those were some novel questions that were asked in TKR and THR that I've basically taught you in the form of questions because you don't need to know everything around them. Which of the following is not true about osteoarthritis? It's an inflammation of the synovial joint, most common joint disease, affects shoulder joint, narrowing of the joint space. Which is not true because it's not an inflammation of the synovial joint. It's basically a disease of the cartilage. It's a degeneration of the cartilage. It's not inflammatory. Pain and arthritis of the distal interphalangeal joint is seen in. DIP involvement is seen in osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, dequervens disease. You know that it is not rheumatoid arthritis. Ankylosing spondylitis mostly axial more than peripheral. Dequervens disease is tenosynovitis of abductor pollicis longus and extensor pollicis brevis. Answer here is osteoarthritis. Okay? So osteoarthritis. Arthritis involving DIP, PIP and first CMC with sparing of MCP and wrist joint, which is typical of, come on, you know this, come on. Right. The answer is osteoarthritis, classical, right? That's why please remember the joints that are usually involved and the joints that are spared. Both of this can help you answer a lot of MCQs on your exam or basically come to a diagnosis. And once you've come to the diagnosis, then you can use your knowledge of theory and answer the question. Which of the following is a true statement? Systemic symptoms are seen in osteoarthritis. Is it true? No, it's false. Rheumatoid arthritis is uncommon in hands and feet. That is also false, more common in hands. Osteoarthritis is an autoimmune disease. No, it's a degenerative disease. Osteophytes are seen in osteoarthritis. Yes, that is a true statement. Osteophytes are seen in osteoarthritis. Next, most specific antibody seen in rheumatoid arthritis. Yes, anti-CCP is the most specific. Most sensitive is rheumatoid factor. Please remember both the MCQs. In which of the following deformities is the distal interphalangeal joint extended. So DIP is extended in which condition? Is it Boutonniere deformity, swan neck, Z deformity, claw hand? Obviously not claw hand, obviously not Z deformity. Swan neck deformity is the flexion of the DIP and Boutonniere deformity is the extension of the DIP. So the answer here is Boutonniere deformity. Quick recall, this is your Boutonniere deformity, flexion of the PIP and extension of the DIP. Swan neck deformity is extension of the PIP and flexion of the DIP. Z deformity is radial deviation of the wrist and ulnar division of the fingers. And claw hand is seen in ulnar nerve palsy where there is hyperextension of the MCP and the flexion of the PIP and DIP. Okay, is that clear? Hammer toe deformity is seen in? Yes, hammer toe is seen in rheumatoid arthritis. The answer is rheumatoid arthritis. What is happening here? There is flexion of the PIP joints. There is flexion of the PIP joints of your toes. Windswept deformity of the knee is seen in osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis. Windswept deformity. Knee. One knee in valgus, the other knee in varus. The answer here is rheumatoid arthritis. Very good. Right? Remember, one knee in valgus, the other knee in varus. Next question. Which of the following is not a feature of rheumatoid arthritis? Swan neck deformity? Yes. Ulnar deviation of fingers at MCP joint? Yes. Symmetric reduction of joint space? Yes. Haberden's notes? No. Haberden's notes are seen in osteoarthritis. What is it? It's basically a degenerative deformity of the distal interphalangeal joint, leading to swelling of the DIP. So Haberden's and Bouchard's notes are seen in osteoarthritis, not rheumatoid arthritis. A middle-aged female of rheumatoid arthritis on treatment develops upper motor neuron signs in her limbs. The investigation required to evaluate her further is spine lateral view, flexion and extension views, open mouth views, swimmer's views, broaden views. Rheumatoid arthritis patient developing UMN lesion in her upper limbs means what is getting compressed? Spinal cord or spinal nerve? Spinal cord, right? So upper limb manifestations, cervical spinal cord is likely getting compressed. Investigation is basically look for that compression because of the bony problem. In rheumatoid arthritis, I told you, rheumatoid arthritis is peripheral more than axial, and if it is axial, rarely it can be cervical. To look for that pathology, you have to look for the stability of the cervical spine. You would need to get a spine lateral view, flexion and extension views to look for the stability of the cervical spine. Okay. Windswept deformity is seen in ankylosing spondylitis, scurvy, rheumatoid arthritis, rickets. Did we just do this question or is it a new one? The answer here is rickets, friends, because I am asking you windswept deformity. I am not asking you whether in adults or children. Windswept deformity mostly usually occurs in knee, and the most common cause is rickets. If they specifically mention adults, then you can say rheumatoid arthritis, or you can mark rheumatoid arthritis if rickets is not given in the options. But the most common cause of windswept deformity of the knee is rickets only. Okay, next question. Windswept deformity of foot is seen in rickets, rheumatoid arthritis, hyperparathyroidism, scurvy. ये बताओ. The answer here is rheumatoid arthritis. Windswept deformity of the foot, rheumatoid arthritis. Knee, rickets more than rheumatoid arthritis. Overall, knee. Knee means rickets more than rheumatoid arthritis. Okay, are you able to answer these 3 MCQs? All are true about Mary Strumpel's disease except most commonly involves the sacroiliac joint. True or false? Ankylosing spondylitis का दूसरा नाम है. It's a different name of ankylosing spondylitis. Yes, this is true. Enthesitis is common. Yes, it's an encephalopathy. More common in males, obviously. Röntgengram is most sensitive investigation. Röntgenogram is basically X-ray. It's X-ray. X-ray is more sensitive. Or do you have anything else that picks up the changes in the sacroiliac joint before the changes on X-ray? The answer is MRI. MRI. So this is the false statement. MRI picks up changes before X-ray, and the changes earliest in sacroiliitis occurs on the iliac side rather than the sacral side. Okay. A 25-year-old man complains of low backache, decreased lumbar movements, and morning stiffness. Aha. So lumbar spine restriction, morning hip stiffness, young male. What else do you want? You already know the diagnosis. Which clinical examination will further help? Head circumference, chest expansion, yes. Hyperextension of joints, no. Plantar arch, no. So answer here is chest expansion. Head circumference में तो malnutrition, children, right? Hyperextension of joints for laxity, Ehlers-Danlos syndrome and such. Beaten score. Charcot joint is another name for joint affected by. Charcot joint is another name for neuropathic joint. Okay, the answer is neuropathy. Most common cause of neuropathic joint is, what is the most common cause of neuropathic arthritis or neuropathic arthropathy or neuropathic joint is? Diabetes. Diabetes, right. Now, in a patient of gouty arthritis, what is the best investigation? Serum uric acid estimation, uric acid in urine estimation, urate crystals in synovial fluid analysis, serum calcium level estimation. Okay, so serum uric acid estimation or serum uric acid in urine estimation. What is the investigation? What is the best investigation in gouty arthritis? Please don't say serum uric acid estimation because it doesn't help. The best answer is to go into the joint, aspirate the synovial fluid and look for the crystals. Urate crystals in the synovial fluid analysis, the best investigation. Because serum uric acid concentration will only tell you what is the serum uric acid in the serum or the concentration of serum uric acid at that moment. It's the sudden change or the surge that manifests the gouty attack. Okay, remember that. Now, which joint is most commonly affected in pseudo gout? You know the answer. The answer is large joints, elderly population, females more than males. Answer is knee joint. Okay. A lady presents with right knee swelling. Aspiration was done in which CPPD crystals were obtained. Next best investigation is ANA, RF, CPK, TSH. What is this question? What is the diagnosis here? Lady, knee, CPPD crystals, calcium pyrophosphate dihydrate crystals. So, pseudo-gout. What should you do? Antinuclear antibodies, rheumatoid factor or CPK or TSH? I've told you that pseudo-gout is more commonly associated with hypothyroidism. So, to diagnose hypothyroidism, you need TSH. So, the answer here is TSH. Okay. Now, the recent question was a 28-year-old man presented with complaints of backache, morning stiffness and redness of the eyes. X-ray image of the spine is given below. Which of the following is the most likely diagnosis? Without looking at the X-ray, can you make the diagnosis here? Yes, you can. Back pain, early morning stiffness, what do you think? It's ankylosing spondylitis. The diagnosis is very helpful with the help of the dagger sign that is visible on X-ray. So please remember this on your exam. Early morning stiffness, young male patient with back pain. What do you think it is? It is usually ankylosing spondylitis. Axial more than peripheral. Okay? Enthesitis, we have discussed all that. And also please be able to differentiate between diffuse idiopathic skeletal hyperostosis and ankylosing spondylitis. The key difference here is in DISH, there is anterior flowing type of ossification under the anterior longitudinal ligament. Whereas in ankylosing spondylitis, there is vertical syndesmophytes both anteriorly and posteriorly, giving you your classical bamboo spine. Okay? Please understand that those two conditions can basically confuse you on the exam, but DISH usually occurs in elderly population, ankylosing spondylitis occurs in younger population. With that, we have basically covered everything that you should know at this level for your exam related to joint disorders. But I strongly recommend that you go and review rheumatoid arthritis or the various connective tissue disorders in medicine, pathology and pharmacology so that you get a better sense of this topic for your exam.